Thank you all. Thank you all for coming. I'm just going to move that further away. I'm a little bit afraid of microphones, but hopefully it'll work from there. So I wanted to talk about walking and balance and prevention of falls and ways that you can improve your gait, improve your balance, and hopefully prevent having falls in the future. And so my goals were to, first of all, talk a bit about gait is our technical word for walking, so gait and balance. Talk about some of the challenges that people with Parkinson's have in terms of walking and balance. Talk about some of the reasons that people with Parkinson's have a higher risk of falls, and then spend time talking about strategies to improve them. So our first question is, how does walking or gait and balance interact? And there are three main functions of walking. So the first one is to walk around obstacles, and so to navigate from point A to point B. The second is to move forward, and the third is to keep your balance both in an upright plane and as you're moving weight from side to side. So in terms of navigation, it can be straightforward, walking across a room, or it can be challenging, climbing over rocks, and we have to orient our body, orient our feet as we walk forward. To move our step forward, when we talk about gait, there are two main phases of walking. The first one is stance, where your foot's on the floor, and the second is swing as you move forward. In the stance phase, the major muscle we need to move forward is the ankle. Is the ankle pushing off, the ankle pushing forward at a toe off, I'm confused about what this, as you see here, that she's having to push off with her toe to move forward. The second important thing is in swing. In a healthy gait, we only have half a centimeter of toe clearance. So if you think of any even small changes in your gait can have a big impact on your toe getting caught, moving the toe forward. So unfortunately, we aren't made to have a lot of wiggle room in terms of that floor clearance as you walk forward. And then balance becomes quite challenging because you're balancing a moving object that's moving side to side as you go from one foot to the other, and at the same time balancing to keep your trunk and your head upright, and we rely on the hips and the knees to do that. So the strength of the hips and the knees and the alignment of the hips and the knees moving forward. In a skilled gait, most of the focus falls on the first roll, on the navigation. So you're concentrating on moving forward, and you have less focus on the progression of your gait and on the balance component of gait. And it's quite a predictable, safe movement. In a challenge gait, so in someone who is Parkinson's or has other walking problems, your attention focuses more on the balance. That's actually me see how everyone else is standing upright? I'm the crouch down trying to climb down the rocks here. I'm not a good climber, so I'm worried about my balance. And so then I'm not able to pay attention to actually navigating down the rocks and to pay attention to moving my steps forward. And in a challenge gait, the gait becomes less predictable. It's a reactive gait, so it's not as safe because it isn't a planned out gait pattern. So if we look at Parkinson's, and certainly I'm talking to a group of people who live with this, so I just want to review things that I'm sure all of you know, but just if you want to play the video. So even in early Parkinson's, we start to see some changes with gait, that the posture changes, and so I talked about that alignment piece. So the forward posture affects balance. Speed will slow down. The stride length or the step length isn't as long. You don't tend to flex or move as much as at your hips and knees. A flat-footed pattern's quite common, and with the flat-footed pattern, as I was saying, all we have is half a centimeter foot clearance. If you aren't getting the toe up, then it isn't as safe moving forward. And then on turning, that also affects your balance because you have to take many steps forward. In advanced Parkinson's, and this is a person who has had Parkinson's for many years and has a lot of difficulty with gait. The steps become quite variable. If you could play that one. Back. Oh, I did that. Let me go back there. So it's just at the bottom there. Perfect. The steps become quite variable. There's small steps, and somebody had asked about cadence. Often in more advanced Parkinson's, you get more steps, almost too many steps, that kind of running gait pattern. There can be what we call freezing of gait, where your feet are stuck and you can't move forward. And then on top of that, having the involuntary wiggling movement and affect balance. So a lot of challenges there. When we look at the muscle forces, we're looking at mainly ankle, hip, and knee forces. And at the ankle, as we said, you have to have that good push off to move forward. At the hips, you have to have good strength of the hip and the knee to keep the upright balance. And then an adequate swing to be able to move the toe forward. I don't know if did you play that one? Sorry, I missed that. Yeah. So the feet are closer to the floor, so it isn't quite as safe. The other thing is attention and cognitive function have a big impact on walking. So we know that in healthy elderly people, as they get older, they have more difficulty doing two tasks at the same time, walking and talking. And there was a study done a number of years ago that found that when people stop talking while they're walking, they're at higher risk of falls down the road. They're actually doing the right thing, though. They're not talking, focusing on their gait, but dual tasking does become more difficult when you're having more balance problems. And also if you're doing a different task, like carrying something, talking on the phone, reading a book, or carrying on a thought-provoking conversation, that also affects your balance and adds to the challenge. In Parkinson's, and Dr. Holmes actually did work on this, and there have been other researchers who have found this same thing, is people with Parkinson's often will focus more on the secondary task, on the cognitive task, and not focus as much on the balance. So the idea of a posture second strategy, which isn't safe. If you're thinking about what you're saying or what you're thinking about and you're not thinking as much about your balance, then you're at higher risk for falls. We also know that when people have cognitive impairment of all causes, and including Parkinson's, that there is an increased risk of falls. And even with what we call minimal cognitive impairment, when you add a dual task on top of that, then the risk of falls will increase. In terms of medications, and you all are living with this, and so you know that the medications are helpful for some things, but they certainly don't fix everything. And the medications tend to help more with the speed of movement and with stride length, and we think of that as being a DOPA or a basal ganglia responsive component of gait. But the medication, unfortunately, doesn't work as well with the things like muscle contraction patterns, so to help improve pushing off with your toe, for balance, for freezing of gait, and the idea of your steps can become variable, that you don't have the even step from side to side. And we know that step-to-step variability increases your risk of falls and impairs your balance. And so that is the timing part. And the medications don't work as well. Fortunately, we do have other things that can help us out. And just quick review of the risks of falls. We know that in Parkinson's disease, you have probably 3 times the risk of falls if you don't have Parkinson's. Gait problems, which are also common in Parkinson's, increase your risk. And fear of falling, so even being worried about having a fall actually increases your risk of having a fall. So it's important to be conscious of that, because that's a factor that we can certainly change. And people who have had Parkinson's for 5 to 10 years, falls are quite common and sometimes recurrent falls. And there are a number of risk factors from the literature that we've identified. And as you can see, and I'm just going to switch to this one, many of these risk factors actually can be modified. So the idea of fear of falling, we can certainly increase your confidence with gait, and having previous falls, so obviously preventing having more falls. We can help improve the regular steps, so the idea of the step-to-step variability. We can help focus on inattention or dual tasking. Reduced physical activity also increases your risk of falls, and so that's an amenable risk factor. And then freezing of gait, and we have some ways we can help deal with that as well. And I'll talk a bit more about that, but there is some research that exercise and activity may actually modify memory difficulties, cognitive difficulties, and may also modify how quickly the Parkinson's progresses. So a few things. And just a word, I know there's an optometrist, a professor of optometry speaking this afternoon. Falls are not always just due to Parkinson's. So things like vision changes, due to, as Dr. Holmes talked about, environmental hazards, medication changes, other medical problems. So I wanted to talk about some of the treatment strategies that we have that can improve walking and balance. In preparing for the talk, it's been a couple of years since I had done a good review of the literature, and I'm happy to report that the literature is brimming. Everyone's looking at research on how to improve Parkinson's through activity, through exercise, through different strategies. And there's been over 200 published articles only in the last 2 years. So there's certainly a lot of interest in how can we improve the lives of people living with Parkinson's. And from the research, there are 4 main areas that have been found to be helpful in improving gait and improving balance and preventing falls, and I'll address each of these. The first one is exercise, and including things like range of motion and strengthening and cardiovascular fitness. Cueing strategies, which Dr. Holmes had talked a little bit about. The laser light is a cueing strategy. The auditory, the rhythmic auditory cueing is a cueing strategy. The idea of cognitive motor strategies, or retraining your brain, both in terms of how to do things and to retrain your thoughts of the day. How am I going to get from here to here? And why am I always having problems with my gait in the bathroom? How can I help deal with that? And then the last one is dedicated balance exercises, and often with using feedback to improve the balance overall. So I wanted to talk first about exercise and Parkinson's and the role in mobility. We know from animal research that exercise will slow the loss of brain cells in Parkinson's, and so in an animal model. So it actually has a neuroprotective effect. And so people always say, well, what can I do to stop my Parkinson's from getting better? And in fact, exercise is probably the best thing you can do. Unfortunately, we don't yet have a medication that can do that, but certainly exercise is the key. And we think it's to do with the fact that there are growth factors in the brain, neuro growth factors, and that exercise seems to stimulate the neuro growth factors, and you need that to keep brain cells healthy. So in effect, we say that exercise makes your brain cells last longer. And that's true for Parkinson's, but it's also true for the cognitive problems for other diseases as well. So for instance, for Alzheimer's, which is a different problem, but also a neurodegenerative disease, there's good research now that exercise can slow the progression of Alzheimer's by up to 5 years. So it can be a big impact. The other thing exercise does, and we see this in human research, is it can stimulate dopamine production. So in Parkinson's, there is a loss of dopamine-producing cells. Dopamine or dopaminergic medication is what we give to help stimulate movement. And when you have Parkinson's, you lose dopamine-producing cells, but you don't lose all of them. And so there are still dopamine-producing cells in the brain, and it helps stimulate those cells to produce more dopamine. In terms of the, yes?
Just to clarify, are you talking specifically about physical exercise, or are you including mental exercise there as well?
Yeah, so the research to date is looking more at physical exercise, which seems a bit counterintuitive, but physical exercise slows the loss of brain cells. Physical exercise also is what they found within Alzheimer's, that slows the progression of the Alzheimer's by 5 years. So it's actual physical exercise. And I think you have a flyer for my colleague, Dr. Penny McDonald, and they're looking at mental exercise. There's a bit more controversy around the idea of how well mental exercise works to slow change. These are actual physical exercises, though. So if we, from the literature, so I said 200 articles in the last 2 years alone, and 200 more before that. We know that exercise does demonstrate an improvement in balance, an improvement in your speed of walking and how far you can walk. We also have found that it helps just in terms of your day-to-day function. So your activities of daily living are improved, your strength has improved. Beyond that, it also has a big impact on what we term non-motor Parkinson's. So things like quality of life, mood, sleep. It can help prevent blood pressure dropping, which can be a problem, as we know, in Parkinson's, partly from Parkinson's and then partly from the Parkinson's medication. And as I said, there are improvements in the Parkinson's rating scales, implying that the exercise may actually be slowing the Parkinson's down, and improvement in executive functioning, or in thinking, clarity of thought, speed of processing. In terms of what to do, and everyone always asks this, it's kind of the good news and the bad news. The good news is it probably doesn't matter, especially what exercise you like to do. And there's been no one exercise that has been proven to be better than any other exercise. And there's been a lot of head-to-head trials of physiotherapy classes versus walking, Tai Chi versus dance, dedicated inpatient programs versus doing an outpatient home program. So there isn't any one type that has been found to be better than any other type. There have been a few research studies looking at intensity, high intensity, moderate or low intensity, and moderate intensity seems to be probably the best. High intensity isn't necessarily better and may lead to more orthopedic problems. In terms of how long to exercise, from a lot of research through the years, most neurophysiologists will say about 30 minutes 3 times a day is the minimum time. For particular individual problems like correcting posture, looking at particular balance problems, things like that, a physiotherapist can be quite helpful to give you exercises to deal with a specific problem, certainly. We want an exercise that will keep you going. So if it's fun and you enjoy it, then you're going to keep doing it. If it isn't fun, then it's kind of hard to say, oh, gee, I'm going to go lift weights for the next hour. Location, so the research has looked at, as I said, exercises done at home, in a clinic, in a physiotherapy gym, in a class-based, and all of them have demonstrated improvements. And I'll just highlight a few of them, things like dancing, walking on a treadmill, doing an exercise class. From physiotherapy studies, there's been many, probably getting close to 100 randomized control trials looking at physiotherapy. A randomized trial means that there are 2 groups of people. One receives one treatment, the other receives the other treatment. Generally, they don't know what the planned outcome is. They're evaluated by somebody at the end who isn't aware of which treatment path they followed and says, I can definitely see an improvement in one group versus the other. So there's been many studies, and they've tried to compare different types of physiotherapy, and the bottom line is that all of them did show improvement. So that's good. It doesn't guide us in terms of which one in particular. Treadmill walking, there have been a number of studies that have demonstrated not only improvement in gait and balance overall, but also this idea of the step-to-step variability. So we know that that is one of the risk factors of falls, that if one step's longer than the other step, then you're at higher risk of tripping, higher risk of falls, and the treadmill has been found to be quite helpful for that. Lots of community-based exercise groups, training with walking. Dr. Holmes and I were involved in a We Fitness and We Exercise program, which did demonstrate some improvement in gait and balance, but also people found it to be fun, and they kept doing it. So it was a motivating program to do. And then dancing, music, as you've heard, is quite helpful in movement with Parkinson's. Tango, and I don't know if it's because people have chosen to study it, but there's been about 4 very good quality studies done on tango dancing as being quite helpful. In patient rehab, there's also been water-based and land-based. And as I said, music therapy, which is also high on the enjoyment factor and keeps people walking. Weight training has been helpful in improving strength and endurance, but it hasn't demonstrated that weight training on its own helps walking. So the idea, I tell people, if you want to learn how to play basketball, then you have to play basketball. So you can't stay in a room and lift weights. If you want to improve walking, then you have to actually be out standing, moving, walking to improve that. I was just going to say, Dr. Holmes and I almost did a dance study, but nobody wanted to see us dance, so it fell apart. It wasn't me, it was him. So the second thing is the cueing strategies. You want to just play the video. So one of the earliest cueing strategies that people realized helped Parkinson's was the idea of putting lines on the floor. And so that helps regulate your gait, so you have an even step to step, and does improve gait overall. That's not a terribly practical thing to do. You can't put tape everywhere you go, and so other visual cueing has been developed, like the laser pointer, stepping over a cane. I've seen people with a ball, and they drop the ball and then step to kind of kick the ball on a string. And those all are helpful in improving the step length and motor strategies, and I'll talk a bit more about that in a minute. Thinking about taking long steps, marching using a heel-toe pattern. And then auditory, as we've heard about the rhythmic auditory stimulation, metronomes. Someone had asked about number of steps, what your cadence is, and so people even have developed something where they take your cadence but then regulate it and develop a self-time tool to your own particular walking pattern, but to help improve how regular it is. They've also used things like a gravel footstep and see if that helps, because it's the idea of your hearing somebody walk. And then counting's often helpful if people are getting into difficulty with freezing or saying left, right. There's been sensory cues. So an insole in a step that will vibrate as you're about to take a step, and so stimulate moving the foot forward and again at the right pattern, and then tapping on an arm, or there's been a study of this thing they call a moving handrail, and it's just a vibrating handrail, and it stimulates as you're due to take your next step. And as I had said earlier, the idea of why we think cueing works, nobody really understands it totally, but we think that the basal ganglia, which we give dopamine to help treat that, helps with the scaling or the size of movement, so it can help improve your step length. But the idea of rhythmic or timing movement seems to be controlled by other parts of the brain, probably by the cerebellum. And by using a cue, like a visual cue is stimulating the visual cortex, auditory cues are stimulating the auditory cortex, sensory cues are stimulating the thalamus. They help use different pathways to improve gait and in a way bypass the basal ganglia. And so that's the theory behind gait in cueing of gait. And so in terms of what cueing can do, it can improve your speed, your stride length, this idea of improving the symmetry of gait so it's more regular. People have demonstrated better heel contact, and that idea of, toe off, when to push off with your foot. And it's very helpful for when people are having freezing of gait. So I think people tend to talk about cueing as helping freezing of gait, and it does, but it also helps gait, period, in Parkinson. So even if you aren't having freezing of gait, it can still help improve the quality of gait, help improve your balance. Cognitive strategies, and if you want to cue that video. So Jeff and I and other colleagues in our lab were involved in a study. This gentleman kindly said I could show his video of him walking. This is him at baseline, and so he has a decreased stride length, as we said, more flat foot. He has a great deal of difficulty with freezing, and he's just trying to turn here at the end of the mat. He's walking on a mat that will instrument steps. So he's now been given a cognitive cue about being conscious of taking longer steps, and we videotaped him with walking at his normal gait and then walking using the cueing strategies. Sent him home with the video and said, every day I want you to look at the video and then go out and practice your gait, practice the longer stride. And he came back, and this is what he was doing. Marked improvement in his gait. He'd gone from falling every day to having no falls over this 2 or 3 month time. He was able to get himself out of freezing episodes, and the interesting thing is, in following people even a year or two later, they can still picture in their mind how the gait looked that was the cued gait, the longer strides, and we're still able to call that up and still able to use that. And we had talked about doing a larger study, which may never happen because I keep telling everyone now to go home and videotape yourself with walking and then think about the longer stems. Videotape yourself, look at that for a couple of minutes every day and think about it as you're going out. So it's using the cognitive strategy as well as giving yourself visual feedback. And it's been one of the most effective strategies we've had. And I think going forward, probably cueing with the idea of the visual feedback or the cognitive feedback probably helps even more. And the type of kind of cognitive or word talking changes that seem to work best are simply take a longer step. And if you take a longer step, not only does it improve your step, it improves your toe off, it improves your heel strike, it improves your swing, your foot clearance improves, and it improves posture. Now that seems like, what? How does that work? I don't know. But it does. So the idea of thinking of taking a longer step actually changes your entire gait pattern. So it's a pretty easy thing to do. I'm just going to take a longer step. Having the visual cue, having the videotape of seeing how it looks, and you got that image in your head, and it moves you forward. There's also you've probably heard of the speech, the Lee Silverman voice therapy. They have a walking component, and it's called BIG, B-I-G, the end. And it also is the idea of the cognitive strategies. Think about taking a big step as you go. And then the second aspect of the cognitive strategies is to think about as you're going. So avoiding doing a challenging second task as you're walking. So, we as physicians and therapists are often the worst people. We get somebody up to walk and we're chatting to them all the time. They're walking down the hall and then they can't concentrate on the walking. But to be aware of that, if you're the caregiver, spouse, friend, and you're out with someone who has Parkinson's and they do have balance issues, don't engage them in an important conversation as you're starting out. Let them get to where they're going and then talk. So just to be aware that we know attention has a lot of impact on your gait. In terms of how to learn cognitive strategies, often you need someone to start you out, a physiotherapist or an occupational therapist. It requires conscious practice, so it isn't something that, well, I'll do and I'll be fine. You have to really think about it and be concentrating. As I said, the idea of giving you the visual feedback helps. There has been some studies that they've looked at a smartphone, that if people are running into trouble with their walking and they stop, then the smartphone will say, take a step or take a big step or something to remind you of things. And with the cognitive interventions, there is an improvement in, again, walking, your speed, your balance, and it also tends to improve confidence of gait. So as you recall, the idea of fear of falling is a risk for falling. So if you have strategies in your back pocket and you know how to use them and you practice them and you get to see yourself, and your confidence of gait improves, and so you're at less risk of falls from the fear. Lastly, balance training. And balance training is usually done by a physiotherapist or a trainer, and it's looking at specific balance training exercises. Practice standing on one foot, standing with your feet together, with your eyes closed, and it's not something that you do in your own home on your own. You certainly want to have help with that, as well as strengthening your core helps. There's been studies looking at focusing on realignment. Sometimes people with Parkinson's will get a change in the alignment of their trunk of their spine, and so working with a physio to help straighten that also is helpful. Things like the Wii balance board that's taking you through various balance exercises. And then Tai Chi has been found to be helpful from quite a few studies with people with Parkinson's for improving balance. And you know, again, as with the cognitive training, balance training also helps this fear of falling as well as the other strategies. And I seem to be harping on it, but fear of falling often is the biggest trigger that leads to people having a repeat fall. Once you've had a fall, you're always worried about that again. And so that's a time to, you know, really try and work on your balance to improve that. And just a couple more words. So in terms of preventing falls, finding the cause is probably half of the cure. So anytime I see anyone who's had a fall, I'm going to ask you a bunch of questions, and it's helpful. You know, you've fallen, and that's a dreadful time, but it's helpful to actually sit down and write down what happened around that time of the fall, because that can often help us figure out what to do to prevent a fall from happening again. And you know, usually when I say to someone what happened and they said, well, I scraped my knee, and then I say, well, no, what I mean is what happened before, what were you doing before and what led up to it. So things like the time and where were you, and what kind of shoes were you wearing, what were you, I can't say it today, what were you doing at the time, was it outside or inside, were you in an off state or an on state in terms of your Parkinson's. So as you know, some people find that the pills work, but they don't last for a long time and go through this on-off. Other people don't have that, but it's always helpful to be aware. What was your mental status? So had you just got up out of bed in the middle of the night to go to the bathroom, you hadn't quite woken up, and then what medications beyond the Parkinson's medications are you taking? So often, you know, people will have a fall because they become lightheaded, and we can certainly look at changing things, right, to prevent that from occurring again. And just a couple of hints, and sort of following up on all of the things that Dr. Holmes has said, is falls occur at certain times. So if we look at, on the average, where are your falls going to occur? Most commonly in the bathroom, in the kitchen, and it's because you're having to reach, you're having to turn, you're in a confined space, you're trying to carry something from the counter over to the table, you're at the counter and you back up and then lose your balance, or you turn quick and lose your balance. So to be aware of that and to guard against it. So if you know that scenario that you don't feel confident, hold on to the counter or hold on to the table as you turn. Don't just jump up and move. Use a trolley or a cart to carry things rather than carrying things yourself. The idea of holding on, turning, and then walking away from the counter rather than backing away. Backing can be one of the most difficult things to do safely. And reaching for a chair, often people will fall getting into the chair and they've misjudged how close they are. So as Dr. Holmes was saying, one of the things Parkinson's can affect is your perception of depth, of how far the chair is away. So get back till you feel a chair on your legs, reach back for it before you sit. And just to follow up with Dr. Holmes, and this is just a very brief summary, but keep the area free of clutter, well lit, have a night light if you're up through the night, and certainly it's better to have a grab bar there and not use it than it is to have a grab bar and have a fall, right? So I think just to be cautious of that, it's probably a good idea to be preventative around things like that. So take-home messages. We talked about the fact that gait and balance are affected both by the motor symptoms of Parkinson's, but also by your attention, by how much attention you're paying, and by memory aspects. Many of these risk factors can be treated. For major treatments that can help are the idea of exercise. Any form of exercise is helpful, but some of it has to involve you standing or walking. Cueing strategies can be helpful to improve your gait, but can also be helpful if you're having freezing of gait. So for both. Cognitive strategies, again, can be helpful to improve the gait. And balance training is important if you're getting into balance exercises, and probably through help of a physiotherapist or an occupational therapist. I think that's it. Thank you. Questions? Oh, goodness, okay. I think they're going to bring it. Oh.
So, Dr. Jenkins, is the fear of falling like a logical thing, or does the fact that once they fall and now they're becoming afraid of falling, does that modify what they're doing, which actually increases the risk of falls, or do we even know?
Yes, yes, we don't know. So I think it's probably both. So that's the brief answer. The longer answer is Parkinson's seems to affect the ability of our brain to process sensory input. So your balance comes from your eyes, your inner ears, and the feeling in your feet. The feeling in the feet may still be normal when we test it, but the integration of that, so the signal going up to the brain to say to the motor, or my feet are flat on the floor, doesn't work quite as well and doesn't work quite as quickly. So you can have a fear of falling even without having a fall, because you just don't feel quite as steady. You don't trust your feet under you quite as well. Certainly once you've had a fall, then it's, that's a really catastrophic event, and so that just heightens it. But really, either is true. I saw a hand here.
If you're a caregiver and
Yes.
you're walking along with the person you're looking after, and they're pushing a walker, and they start to freeze up, is there anything that you can say to them to help them carry
good
on
question.
moving?
Yeah, okay. So freezing of gait is quite a complicated thing, and we're understanding more about it all the time. One of the things is that anxiety increases freezing of gait. So the first thing is stay calm, I guess. Don't rush the person. If you try and pull them along, as you found out, or push them along, then they're in even a worse freezing of gait. So things like the cueing strategies can be helpful. So, take a breath, take a minute, we're okay. Now take a big step. Or some people, the difficulty with the cueing strategies is the same ones don't work for everyone, so you have to try a few. But take a big step, marching on the spot, stepping over something. So if you put your foot right beside, step over my foot. Say left, right, try counting. Some people find focusing on an object far away and saying, well, I'm going there, that'll help starting. So, all of those kind of things can help. And it's almost the person that has the freezing that has to figure out what one's going to work for them. So I often find that I'll tell people to do this, and they'll say, oh, well, I found that helped. And one gentleman, I followed the fellow who was in the study who was having lots of walking problems. He got one of his grandchildren's rubber toys, and he put it on the walker kind of at the bottom, and if he was frozen, he would lift up his foot and kick it, and then he'd be able to keep going. So it just broke the freezing. The idea of the freezing, it's like the basal ganglia is in a having a bit of a fit, and it can't move forward. So you have to do something to bring your conscious motor brain into working. So I hope that's helpful. Yeah. Oh, somebody here. Here are many people. Okay.
I have a real fear of falling up and down the stairs,
Yeah.
and I'm looking at each stair as I go up it and down it, but it's just becoming quite dizzying. Is there
Right.
anything you can suggest to help that?
Yeah, stairs are a difficult thing, right? Because there is certainly risk of falling on stairs. Certainly having, ideally having 2 handrails, if you can, is better than one, then you've got a better grip. And I think if you're really having difficulty with that, it would be helpful to work with a physiotherapist or an occupational therapist on gaining your confidence. Now, there are times when you say, this is too dangerous, and maybe I'd be better to have a chairlift. Maybe I'd be better to go this safe way. But often you can avoid stairs altogether. So I think, getting help working on that. But certainly having the 2 bars would be a big help. Do you have anything else?
Yeah.
to that?
Do I need to learn how to keep my head up?
You want to watch where your feet are going to. So there's a happy balance between having your head up and seeing where your feet are, because I talked about the fact that you can't judge as well where your feet are in space. So I think you probably need to be looking at the step as you go. Yeah.
Is there any evidence that DBS surgery affects gait in negative or positive ways?
Oh, you guys ask all the hard questions. There is a little bit of evidence that it may have a negative impact on gait, although that's a bit equivocal, right? So it certainly doesn't help gait. So it helps wearing off, and DBS, the deep brain stimulation surgery, makes you as good as you can be on your best on time. So it won't make your gait better than it was before you had surgery and your best on. They are looking at implanting the electrodes in the brain stem. So there is what we call a gait center in the brainstem, and they're looking at implanting the leads there, and there has been some recent research that it does seem to help gait. So they are trying to deal with that. The current DBS targets, though, don't really help it.
This is not specifically for you, although all the speakers have used the word cadence
Yeah.
in a way that I'm not
Okay.
used to.
Sure.
Could you define
Yes.
cadence?
So cadence is the number of steps per minute. And stride length is how big each step is. So in people that have Parkinson's, usually the number of steps that they take doesn't change, but the length of the step can. And sometimes, as you saw in the one woman that had quite advanced Parkinson's, she was actually taking more steps per minute. They're small, but more frequent.
I'm used to the word being used to describe tone or a sound. And
Oh, I see what you mean, like a step. Yes, good. Well, I'm
and-
glad you asked that then. Sorry. Yeah.
Okay,
Yeah.
thank you.
At what point do you call a fall a fall?
Always.
Always?
So
How far down do you have to go before it's a fall?
In research, they would say you have to hit the floor, but truly, if you're having stumbles, that's a warning sign, right? Take it as a warning sign, and what can I do to help that? Yeah.
Just a point of clarification. Your slide made it clear, but I want for the auditory learners in the room to just underscore that the exercise that you're advocating is a minimum of 30 minutes per week, not per day. 30 minutes 3 times a week, not 3 times a day, because you're going to scare them away from exercising.
That's right.
If it's 3 times a day.
Did I say 3
Yes.
times? I'm sorry, but my slide said 3 times a week. Good. Sorry, 30 minutes, thank you. 30 minutes 3 times per week, right? So an hour and a half in the week is the minimum. And, you know, doing a little bit more maybe helps a little bit, but, you know, I have people who, I saw this woman and she said she walked 10 flights of stairs a day or something. And I said, well, you know, you probably don't need to be doing that much. So you don't want to overdo it. Yes, sorry, 30 minutes 3 times per week. Yes.
Recently, Gordie Howe once was into at least had a not a brainstem, what do they call it? No, well, he had a stroke, and then he also had. Oh, I'm sorry, I forgot.
Was it
stem cell? Sorry, that's it.
right?
He had stem cell injection.
Yeah.
And there was a noticeable improvement in his condition. And I'm just wondering if we have any work going on in Canada regarding that.
Yeah,
And
yeah.
Could you
So,
maybe briefly?
Yeah, there's a lot of work going on looking at stem cell treatment for Parkinson's, and it's still very hopeful. One of the things is maybe 15 years ago people were doing stem cells for Parkinson's, and there was concerns because some people felt that they weren't doing that well. So they did a very dedicated randomized controlled trial where they took 2 groups of people. Both of them went to the operating room. Both of them got cuts in their head. Half of the group got stem cells implanted, the other half didn't. Nobody knew who had what, and they followed them. And the group with the stem cells did worse than the group who didn't. So at that, and it's because the stem cells grew, but they couldn't stop them. So they almost turned into a tumor. And people developed these wild dyskinesias that they couldn't fix, that they couldn't stop. So the kind of good news is we know that the stem cells grow. We know there's a potential to use them. We have to figure out how to get them to the right place and how to stop them from continuing to grow. So it's, you know, it's certainly promising, and there's a lot of research worldwide going on it. There's a bit in the States, not as much because there's lots of controversies with that, but in Europe and in Canada there's a lot of stem cells, and there was a recent update by Tony Lang, who's the big Parkinson's guy in Toronto, and he was saying that you know, they're getting closer, but we're not quite there yet. So it's still hopeful. But don't go and have it done somewhere. No, thank you. The problem is, and I can't comment on why he got better. With a lot of programs, and they're out of country, people get an intensive 4-week physiotherapy program at the same time as they get the stem cells. So the question is was it the physio, was it the stem cells, was it both? Yeah.
A question. I was interested in your answer to the lady who was watching where she was going. As you may be aware, my dad, who I take care of is very hunched over. And when he walks, the more hunched he is, the faster
That's right.
his steps go.
Yeah.
And so we're frequently trying to get him to straighten his back.
Yeah.
Is that turn something that physio can help with, number one? And how do we, make an adaptation there?
Physio can be helpful. I mean, it's a lot of exercise and a lot of work, and you have to be able to certainly tolerate that, but certainly physio can be helpful to improve the posture. When someone's walking, you can look ahead and still see the floor, so you do want to try to encourage them to get up. Taking longer steps will also slow him down. So if he thinks about taking a longer step, then he won't get into that really quick, rapid running. But again, it's a conscious thing, having to concentrate on it, yeah.
I'm just wondering around the fear of falling, taking it a little bit beyond just the physical. Is there anything happening where when we're in fear, we stimulate a whole lot of chemical stuff in our body that promotes anxiety, and then we just get more of what we're thinking about? So that would be like neuropsychology or cognitive therapy.
Yep.
So is there anything happening that when we get fear of falling, that we can assess that we're safe, and then learn to send a message to our brain saying, I hear you, but right now I'm safe,
Yeah.
and try to get the chemicals that get you back into the happy feeling, so that we can learn to be aware of what's happening, but to talk ourselves into a better state of mind.
Yeah.
Are we working on that at all yet?
Yeah, so the idea that fear of falling leads to falls is actually a new idea in the literature. So you would have thought that we always do that because it makes sense, but I don't think, I think people said, oh, well, you're fine, you're just worried about it, you're okay, you're good. And I think it took a lot of studies to be able to say, oh, okay, there is actually something here. And certainly fear of falling does a lot of bad things. You're right, it raises chemicals which increase anxiety. We know fear worsens freezing, so if you're already freezing, that will get worse. I'm sure there are lots of things going on about that. There isn't anything published, but it is one of those cognitive strategies. It's the idea of cognitive self-talk. I think when you're at a state that you're afraid of falling, it's such a powerful stimulus, right, that it takes a lot to bring it back. But I think certainly that's a big avenue to look at in the future, a big avenue.
Working in a shoe department, we have specific shoes for specific activities. But then listening this morning, with the stride and the stance and the clearance and everything, for example, if you're shuffling or having trouble freezing or anything, you don't want a shoe with a whole lot of traction that's going to trip you. Is there a general rule of thumb of what type of footwear? And now it'll be different for whatever stage of progression you're at, but we don't want to put the wrong person in the wrong shoes.
That's right. And it's a little bit individual, so I hate to make generalizations, but people will tell me that if they are having more of a shuffling gait, that they'll tend to try to get a leather sole rather than a rubber sole. When people are feeling unsteady, then they want a sturdier shoe like a runner. So I learn as much from my patients as I tell them. So I think people know what they need. So I would always say, how does this feel? How do you feel with that? What are the issues? Yeah. Is there somebody back there? No? Okay. Oh, I think we're done. Any other questions? No? Thank you.